This leads us to the final and most practical question. Why is the study of abnormal psychology so critically important in the field of counseling? The answer is simple. It's the bedrock of the entire profession. It's the what that precedes the how. A counselor who does not have a deep and nuanced understanding of abnormal psychology is like a surgeon who has not studied anatomy. They may have good intentions, but they lack the fundamental map of the territory they are claiming to heal. First, and most fundamentally, the study of abnormal psychology is the basis for identification, assessment, and diagnosis. A counselor is a trained professional who must be able to listen to a client's story, a story that is often chaotic, confusing, and painful, and begin to recognize the underlying patterns. When a client says, "I'm just so stressed out," the trained counselor's mind begins a process of differential diagnosis. Is this normal life stress? Is it GAD? Is it panic disorder? Is it PTSD from a past trauma that's been reactivated? Is it the agitation of a depressive episode? Is it the wired feeling of a hypomanic episode in bipolar II disorder? These are not just academic distinctions. They have radically different implications for treatment. A counselor must know the flavor of the suffering. This skill is also life-saving. A core component of studying abnormal psychology is risk assessment. The counselor must know the warning signs for suicide, the factors that increase risk, and most importantly, how to ask the direct, unambiguous questions. Are you thinking about killing yourself? Studying this field gives the counselor the knowledge and the courage to go there, to step directly into the most dangerous and painful parts of a client's experience. Second, this study is the foundation for case conceptualization. A diagnosis is just a label. It's a shorthand, a starting point. It tells you what the person has, but it doesn't tell you why. A good counselor does not just treat depression. They treat a person who is experiencing depression. This is where the biopsychosocial model becomes the counselor's most powerful tool. The counselor's job is to build a conceptualization, a story or theory of why this specific person is experiencing this specific disorder at this specific time. Imagine two clients walk into a clinic and both meet the DSM criteria for panic disorder. The first client, Client A, was in a bad car accident 6 weeks ago and now has panic attacks whenever he gets in a car. The second client, Client B, has no obvious trigger. She has a family history of anxiety, bio, grew up in a chaotic home where she was taught the world is unsafe, psycho, and is currently in a high-stress, unsupportive marriage, social. Client A, with a clear traumatic trigger, might respond beautifully to a short-term, focused treatment of cognitive behavioral therapy, CBT, and exposure therapy for driving. Client B, however, will likely not. Her panic is a symptom of a much deeper, more complex web of issues. She will need work on her core beliefs, her family of origin wounds, her current relationship dynamics, and may also benefit from medication. They have the same diagnosis, but their treatment plans must be radically different. Without the map of abnormal psychology, a counselor would be lost. Third, the study of abnormal psychology is the prerequisite for evidence-based treatment planning. The field of counseling is not just supportive listening or giving good advice. It is a science-backed profession. Over the last several decades, rigorous research has shown us that specific treatments are most effective for specific disorders. We know, for example, that exposure and response prevention, ERP, is the gold standard, first-line treatment for OCD. We know that dialectical behavior therapy, DBT, is the most effective treatment for borderline personality disorder. We know that prolonged exposure and EMDR, eye movement desensitization and reprocessing, are two of the most powerful interventions for PTSD. A counselor who tries to talk through the root of a client's OCD-based contamination fears is not only being ineffective, they are likely making the OCD worse by engaging with the obsession. A counselor who does not understand the unique needs of a client with BPD may become frustrated by their emotional intensity and push-pull relationship dynamics, potentially re-traumatizing the client. Knowing the what, the diagnosis, dictates the how, the treatment. To practice counseling without this knowledge is, quite frankly, unethical. Finally, and perhaps most profoundly, The study of abnormal psychology is the antidote to stigma. It is the engine of empathy. It is what allows the counselor to move from a place of judgment to a place of compassionate, non-reactive understanding. When a client is engaging in what looks like manipulative behavior, the trained counselor can see it for what it truly is, a desperate, learned, and dysfunctional attempt to get a legitimate human need met. When a client with BPD, terrified of abandonment, suddenly screams, "I hate you," the untrained person reacts with defensiveness or hurt. This is countertransference. The counselor, armed with their understanding of the disorder, can see past the symptom to the wound. They can recognize this as splitting, a defense mechanism born of terror. They can remain grounded and say, "I hear how angry you are, and I am not going anywhere." This ability to depersonalize the symptom and repersonalize the human being behind it is the counselor's superpower. It is what allows the client, often for the first time in their life, to be fully seen in their pain without being shamed for it. This in itself is a profoundly corrective emotional experience. When a client comes in believing they are insane, a lost cause, or a bad person, the counselor can offer a different, more powerful narrative. You are not broken. You are not a bad person. You are a person in pain, and you are experiencing the symptoms of a well-understood, treatable condition. This is not your fault, and you don't have to go through this alone. In conclusion, abnormal psychology is far more than an academic catalog of human misery. It is the systematic, scientific, and compassionate study of the many ways the human mind can break and the many ways it can heal. It is defined by the very real, very human metrics of distress and dysfunction, the internal pain and the external impairment that prevent a person from living a full life. It is not a separate world from normalcy, but a continuum, a threshold of suffering that any one of us could cross given a certain combination of biological vulnerability, psychological history, and social stress. For the counselor, this field of study is not optional. It is the entire foundation upon which ethical, effective, and empathetic care is built. It is the map that allows the counselor to navigate the client's complex inner world, the science that provides the right tools for the job, and the lens that transforms judgment into compassion. To study abnormal psychology is to study the human condition in its most challenging forms. And to do so is to arm oneself with the knowledge and the heart required to sit with another person in their darkest hour and, with skill and grace, help them find the light.